Well, it's 12:30. Welcome to everybody. My name is Diederik Arendonk. I'm the coordinator of the European Forum for Primary Care, which is your host for today's lunch webinar. Kicking off for a series of webinars with the main subject of the patient perspective within primary care. And of course, to make that happen, we need to explain that. And we found this distinguished lecturer, Dolf de Boer, in fact, a colleague of me here at the NIVEL building, Health Services Research Institute in the Netherlands, who does a lot of research on patient perspective. So we cannot have a better lecture on this to kick off this whole series. Before giving him the floor, see in my background our conference this year of the European Forum for Primary Care in Ghent, Belgium. Still the possibility to submit your abstracts. So we would welcome them very much, and as usual, also there in this conference, the patient perspective is key. Having said that, Dolf will introduce himself further. Dolf, the floor is yours, and you can share your screen, and I will shut my microphone, which is for everybody the best to have his microphone closed. Then he can talk quietly. Please, go ahead.
Thank you very much, Diederik, for the opportunity to speak here and also for your kind introduction. I'll start and share indeed my screen. Then hopefully you will now. Okay, we had practiced this so nicely, Diederik. I'm trying to get it to the presenter mode, but that didn't happen yet by the looks of it.
Okay, yeah, I see. Well, then it's without the presenter mode. It's still possible, I think. You can try once again.
What I will do is close the presenter mode.
There it is. But now you need to have your, yeah.
This must be better, I guess.
Much better. Go ahead.
Excellent. Okay, so yeah, it's my honor to share a little bit about our work on the patient perspective. And I'll start with introducing myself a little bit, so you know where the input of today comes from. My name is Dolf de Boer. I'm a program leader at NIVEL, and the research program that I'm leading or managing is called Care from the Patient Perspective. I have a background in psychology and also a little bit in healthcare management. And I have a lot of experience with patient surveys, also stakeholder involvement, because if you do a survey, you have data and you hope that stakeholders will use it to improve care. And I also have, in that regard, a special interest in the usability of data. To show you a few of the key projects that we are working on currently. We have what we call the Transparency Monitor, which is really about studying how information facilitates the patient in his or her journey, and also in professionals in supporting that journey. So you have to think about things such as shared decision making, quality improvement, dealing with patients with lower health literacy. All those sort of things are all in this project. We also have what we call the Citizen Platform, which is where we involve citizens, patients in more complex policy and management issues. I'll talk to that a little bit later on as well. But it's a very nice way and surprisingly effective way to have in-depth discussions with patients or citizens about complex things in healthcare that you would normally not expect to be able to discuss in that manner. And then another big one, which is the OECD Paris survey for people living with chronic conditions. You may have heard about this. It's a very big initiative by the OECD And I'm currently leading the consortium that is implementing this project in over 20 countries. And it's very much focused also on primary care, so you may have heard something about it. Okay, so far a bit of my background and the expertise that I can share from. What I would like to do now is think a little bit also together with you on the patient perspective, from the perspective that it is also always wise to start with the end in mind. And I'll go through the bullets on this slide, but I would also like to announce that I would like you to think about these things from your own perspective. And in a minute, we will transfer to Mentimeter. And I would like you to feed in your own perspective from your own work on why you would want to involve the patient perspective or why you would want to assess it. So if you begin with the end in mind, you should always think, what is the ultimate goal of assessing or involving the patient perspective? Would that be quality improvement? Would it be accountability, payment by results, patient choice? It could be many things, but it is good to be aware from the very start where you want to end up. It's also important who the audience is, and that's basically the people that are in a position to do something with the results. That might be healthcare professionals if it is about policy improvement. It might be payers if it is about payment by results. It might be patients if it is about facilitating patient choice. And then, of course, what type of decision must be made? Would it be about reimbursement or improvement of care pathway or commitment of additional resources? And what kind of information does that require? And well, the feasibility of that, we'll get to that later. But these are a few of the things to think about. And, what I will try to do now, can you still see in the chat earlier when testing with Diederik, I shared a link.
It's still there, so
It's
you should be able to find it at 6 minutes past 12.
I see a few people saying that that is not the case. So I'll share it again. And in the meantime, if you click the link in the chat, you should immediately land in Mentimeter and be able to share something from your own work in terms of the patient perspective. And in the meantime, I'll stop share my screen and try and share the Mentimeter screen. Diederik, could you monitor the chat if any people have problems with Mentimeter?
Yes, and at least for me, in my case, it doesn't open by the link you mentioned, but I can open menti.com, but then we need a password or a code. I see it now.
It is on the top of the shared screen indeed.
Yeah,
yes.
thank you.
So we have a few responses already about better adherence, quality improvement, co-production of health. Excellent. Well, we have quite a few responses already. And I think a couple on things that I also mentioned in terms of improving quality of care. Also a few that trigger my interest. For example, the adherence. It's not something that I come across very often, but it's mentioned a couple of times here. Would anybody care to explain a little bit more about adherence as a goal of assessing or involving the patient perspective? Please just unmute, and I can't see who the sender was. No.
I was not a sender, but I can understand that it's important, because if you want people to adhere to a treatment or to an intervention, the treatment or the intervention should be tailored to their needs, and only when that's the case, people can be able to adhere. So, but I think that could be the case.
Well, it makes a lot of sense, Maria. Thanks for that. And in the meanwhile, Ofra also raised her hand. Could you elaborate further, Ofra?
Hello, I'm Ofra Balaban. I'm from the chair of Gen Patient Fertility Association in Israel. We are the patient. It's all about us. We need to be part of the treatment. We need to be part of the stakeholders. We need to be part of the conclusion, comments, resolutions, anything that comes out, because doctor is a doctor, is a caregiving, but he is not a patient. And we need the everything to be in our language for us, and to take in consideration what we are thinking and what we are facing, because the doctor can say, go do some test. He doesn't know how much bureaucracy behind his request, for example.
Mm-hmm.
And we come and say, listen, you
Yeah.
want this and this test? Keep in mind, it will take 2 or 3 months to get over all the bureaucracy, for example. And we want efficiency, and we want equal treatment all over Europe, or
Yes.
let's say globally, but this is a wishful thinking, but this is what we want.
Yes.
And we are doing all our best to make it happen. I thank you very much.
Thank you, Ofra, and I fully agree, of course, with your views. But thank you very much for bringing that up, and nice to have somebody also from the patient perspective on the call. Okay, I think there were a few other things in terms of quality of life. I'm going to go into that as well, and quality of care, and shared decision making. It's good to hear that many of the things that have been raised are also already in the presentation. That is always nice. But thank you very much for this input. And what I would like to do is, at the end of my presentation, open the floor again also to share a little bit about experience between the participants today on these things. What I will do now is stop sharing the Mentimeter and share again the presentation, which hopefully has happened now. So, yes. Okay, so if we move on to how to assess the patient perspective, there are broadly 2 types of methods. You have quantitative methods, which is mainly questionnaires, and you have, of course, qualitative methods, which is really about interviews, focus group discussions, and open answers. And it's 2 entirely different types of methods. And I'll start with qualitative. And of course, the most important thing, as with all methods, you can't really say that one is better than the other. It really is about the fit between the method and what you're actually trying to achieve. That is important. For qualitative approaches, the basic question is what kind of experiences, attitudes, opinions are present in the population. So it's really not about numbers, it's really about different types that are present. And you could, so examples of qualitative approaches are focus group discussions. I think it's very familiar. In-depth discussions with about 6 to 10 patients on perceptions, attitudes, opinions, beliefs, often guided by a topic list. You also have the individual interviews, of course, with a similar focus. And I think it's a very interesting thing also to do the individual interviews, because I think it is very important to also involve people with limited health literacy in these types of methods. And you can often talk to them better in an interview than in a focus group. There's usability testing. That's actually quite different. That's really about whether tools or instructions or web applications, whether they work well for patients. And what you then actually do is you ask them to use it while thinking out loud. And by following their train of thought, you can immediately assess whether the tool or the instruction aligns with their intuition. And that is a very easy way to identify very important opportunities for improving the usability of these tools or instructions. Then finally, this citizens platform that I talked to you about a little bit earlier. Here, what we do is we engage about 20 to 25 citizens or patients in complex policy or management issues. It's generally full-day meetings structured through a program with many interactive working modalities, also in subgroups. And what I really like about this is that we also involve experts and stakeholders. They are present. They often also inform the discussions a little bit. We always are a bit careful, of course, that they do not influence the discussions. So we really brief them and put them in a very specified and contained role. But it's really valuable to organize discussions that way. And what we often find is that if patients or citizens are also talking to each other, they learn very much about a complex policy or management issue in a very short time and are able to think with the policymakers or with the healthcare professionals in much more in depth than you would normally think is possible. Okay, if you work with these qualitative approaches, it is of course important to also be aware of methodological principles. And there's a couple that I think are important and I would like to share with you today. One is the principle of diversity. As I said earlier, the basic question is, what kind of experiences or attitudes or opinions are present in the population? And you don't really want to miss anything. So if you only talk to white males of about 60 years old, then you won't have sufficient diversity if your population is a lot broader. So you really want to have very many different types of people from the population that you are interested in. The other principle is that of saturation. So you talk to these people in focus groups or in interviews or in other methods. What you would really like to achieve is that you are at a point with data collection where you don't collect any new information anymore. And this point is called saturation. So if you have a diverse group and you don't find any new information, you have what you need. And the interesting thing is, at least this is typically very interesting for people with a quantitative background. They always think that you need very big sample sizes, but for qualitative research or qualitative methods, that is not the issue. There have been various studies on when you achieve this point of saturation, and often it is somewhere between 6 or 10 participants. So you can actually do that with very small samples. Now, I also like to think a little bit with you and also with people in general practices who might want to involve their patients a bit more on the pragmatic point of view. Because we have, of course, many scientific principles. And if you want to do neat scientific research, you should adhere to them. But pragmatically speaking, you don't always need to. I would like you to consider this, that maybe you work at the healthcare provider and you want to talk to a couple of patients in your practice on their experiences. And after 3, you found 2 convincing priorities for improvement that you can work on. And you say, okay, I'll leave it at that. Well, then you probably have not reached the point of saturation, and you probably have not had a very diverse group, because that is difficult with only 3 patients. But I still think you've done a pretty good job. So I'd like to convey that because what I find in my own work is that very often when people want to involve the patient perspective or want to measure the patient perspective, it very quickly becomes very complicated. And sometimes that is necessary, but in other occasions that's not necessary at all, when you could be a lot more pragmatic. Okay, I'll leave it at that for now for the qualitative input I'd like to share. In the meantime, are there any questions about what I shared so far? If not, I'll go on with quantitative, but if you want to ask me anything about the qualitative slides, then please go ahead. I see people nodding no, so okay, I'll carry on then. Okay, so if we look at quantitative approaches, the basic question is a bit different. It is not which type or which kind of experiences, but it is really how many of each type of experiences, attitudes, or opinions are present in a population. So if you have people that are very satisfied with the care they receive, you want to know what percentage of the population is satisfied, or what percentage of the population is not so satisfied. That is what you want to know here. Main examples are patient-reported experience measures, as they are called. It's really about the experiences from patients with the process issues and the structure issues in healthcare. So it could be about waiting times and accessibility. It could be about the information they receive. It could be about their experiences with the process of shared decision making. These types of things you will find in PREMS. So really about the quality or the service of the interaction. The other thing, and I think that this is a pretty hot, as you could say, at the moment, and it's been so for a couple of years, is the patient-reported outcome measures. They are really about functioning and about the quality of life. And it could be physical functioning, such as the example that you see here from the Oxford HIP score. It could also be a mental functioning in terms of such things as anxiety or depression, and also social functioning, whether people are able to participate in society. And it's actually quite a complicated measure from the point of view of healthcare, because often what you want to measure is not just the quality of life. Often what you want to also measure is the impact of healthcare on quality of life, and that makes it quite complicated. I'll get back to that in a minute. Now, for quantitative approaches, there are also a couple of methodological principles, and I think most of them will be familiar to you in one way or another. It's really about reliability, the precision of your measurements. Are they precise? It's about validity. Do you actually measure what you want to measure? About representativeness. Are the people in your data, or are they actually representative? Do they reflect well the population that you are trying to study? you would do something with benchmarking. For example, you would compare PROMs or PREMs between various healthcare providers or primary care providers. You also have to think about the comparability of that data. So that brings a lot of complexity to these types of methods. You also need substantially larger sample sizes, generally a few hundred or more. And ideally, you would determine the sample size based on power analysis. And you can do that if you have performed the study or have used those instruments previously, because you need things like the variance of your measures to actually conduct a power analysis. So that is quite different actually from the qualitative approaches. A lot more, a lot bigger sample sizes are needed, and the types of methodological principles are very, very different. Now, if you would, in your own work, want to do something with quantitative data on the patient perspective, you will probably ask yourself, should I do something with the PROMs on the quality of life and the outcomes, or should I do something on PREMs, focusing on the experiences of patients with such things as accessibility, information, communication, those types of things. Well, if you make this choice, it will probably very much depend on what you would ultimately like to achieve with your study. But one thing I would like to convey is that PROMs are substantially more complicated than PREMs. We have seen in our own work and also in other countries that they are quite difficult to implement. It can certainly be done, but it takes a lot of effort. Data collection designs are often quite complicated because typically you would need repeated measures because you're interested in the impact of care over time. And then you would also need to organize that you can link these measures, which is a logistical challenge. And you need to make sure that that at the different points in time, you have to organize that you ask patients at the point in time that you also best complete these measures. So that's complicated. It's also the case that not all patient groups are in favor. We had once the assumption that, virtually all patient groups would be keen to fill out these surveys for PROMs and also discuss them with their doctor. But we quickly learned that that is not always the case, particularly with chronic conditions where people, their functioning declines over time. They are not always too keen to continuously discuss that with their doctor based on these data and these graphs. And then for use in the consultation room or ambulatory monitoring, you also have IT challenges. So that's not to say that you should not go for PROMs. I think it is very interesting, but what I would like to convey is that it requires substantial resources and efforts to use PROMs. So either you should make sure that you have those resources available, or maybe it's good to reconsider. Okay, then moving on to PREMs. I'll go into this in a little bit more detail. So if you would want to go and do something with PREMs, where would you start? Well, one important thing at the start is always to define a goal. We discussed that previously. And then it depends a little bit on what that goal is, but you may very well be able to join existing initiatives. So in the UK, you have the GP patient survey, which is a big one. In the United States, you have the Consumer Assessment of Healthcare Providers and Systems, the CAPS. In the Netherlands, we have the Consumer Quality Index. I also shared a little bit about this OECD Paris survey for people with chronic conditions that will be implemented in many countries. And you might find that if you want to do something with PREMS, that you could join an existing initiative in your country and work with that. If you are a provider and you cannot join an existing initiative, you could at least consider to join forces with like-minded providers. So you won't have to do it alone. And what I think is very important, and that goes, I think, for any types of survey research, it is very important to use existing questionnaires at the start. So for your own goals, you might need a specific type of questionnaire, but you could probably populate that with questions of existing questionnaires very well. So always scope what is already there, I would say. Sampling, data collection and analysis, I won't go into that in too much detail because I think the session is a bit short for that. But if you have the expertise already, that's great. And if you don't, I would certainly, I think it is important to involve an expert. Okay. And then at some point, hopefully, you will have data. And I think that's always a very interesting step because I quite often have found that I was involved in projects where there was a lot of effort into selecting a questionnaire to use or developing a questionnaire to use, setting up data collection, setting up the analysis and the reporting. And somewhere in that process, I often found that an implicit assumption was that as soon as the data would be there, people would know what to do. And I can tell you that that is not the case. Just to make that a little bit more intuitive, I have here some dummy data from provider A. It could be you or a healthcare provider you work with. On the question, when you had important questions to ask a doctor, did you get questions that you could understand? And here we say that 10% have pretty bad experiences with this. 50% they say usually I got answers that I could understand, and 40% says always. And from these types of data, it's still very difficult to think, okay, but if I want to improve care or I want to understand the care process behind these data, then these data alone are not going to be enough. What often happens is to get a sense of, whether results are very good or bad, to compare it with other providers. And here I've done that again with dummy data, and it tells you a little bit more, but it still doesn't tell you, I think, what you want to know in terms of, do I need to improve anything, and if yes, what? So what I'm trying to convey here is that if you have data, you know what you score, but you don't know why you score what you score. And if you want to know that, you really need an additional process to get there. And this process that could consist of various ingredients. But I think what you really need is you need some sort of brainstorm with professionals or with patients on these data to try and understand the reality behind it. And that could involve additional qualitative methods. It could involve a study of answers to open questions in questionnaires. It could involve many things. But it is important to think about that to get from data to better care, that really requires an additional process that must be organized and resourced. Okay, those were my slides on the quantitative approaches. I'll carry on with a few more, and then I'll open the floor for questions. And also, I would like to invite you to share your experiences with these things. As I said, I touched upon these quantitative methods as well as these qualitative methods, where we've seen that they are very different in nature and methodological requirements. I think this is also has become clear during the presentation that it is important to think about the goal of what you want to do, the audience, what type of decision must be made, and what kind of information that would require. And in terms of the feasibility, I was going to come back to that. I think particularly with PROMs, we have seen that often the data collection and the ultimate the data that you receive, feasibility is often an issue. And what hopefully also became clear is that, you know, it is really important to think about the process that you need to get from data to better care. Okay, so I think that is what I wanted to share, and I would be very interested now to hear it from you and any questions on the things that I have shared today, but also any thoughts from your own work and your own situation on how to assess the patient perspective and involve patients within your work.
Dolf, there are already some questions in the chat. I can read them for you, but you can find them as well. So there was the question, how do you ensure all patients, even them with limited health literacy skills, are able to report?
Yes, that is very difficult. This is a problem, you can only make it smaller. You cannot fully solve it. But what you can do is, so if you do this with surveys, it is very important to have a very good usability test of the survey. So you ask people to read out loud the survey and you immediately understand this question, I phrased as much too complicated. These answering categories, I'm missing one. These things that you find out. And that I would really recommend that. I would never, and I would seriously say, never work with a survey where such a usability test, or we also call it a cognitive interview, if it has not been done, don't work with this survey. First do this, refine the questionnaire, and then start working with it. I think it is also important to note that then still you will miss people, because some people can't read and write. And I think if you want to involve them as well, which I think is a very noble and important thing to do, you will have to do something with interviews.
Yeah, the other one is what about prevention and education?
Yeah, I think that's a very important topic, also a complicated topic. As a researcher, you often work with patients that already have a diagnosis or are already in care in various places. So I'm a bit, what do you call it? I feel a bit like I'm on the spot, but I did not really think about this prior to the presentation. And it's also something that somehow it seems a bit like it's not often on the table of the people that I work with or in the projects that I'm doing at the moment.
Don't you think that this is the problem? That it's not on the table, prevention, and make things worse? Education, it's patient perspective. It's important for us as patient NGOs.
Yeah, I think you are right, Ofra, and it really also depends a little bit on the topic. So I happen to know that it is really on the table for screening in oncology, for example. And then you do have these issues of, you know, people need to make a decision whether they have these screenings. And that's very complicated to communicate, and then you get all these issues of how you present that to the general public. But in terms of people, well, I don't know what kind of specific examples you had in mind, Ofra, but it's not something that I come across in my work very often. If we do something with PREMs or we do something with PROMs, it is in patient populations that are already in care.
maybe something else. What interests me, having a lot of participants from Austria, also the managers. I saw Tobias Schwenner. If you look at this presentation and you want to improve the quality of care within your care provision, your services. What is now your conclusion? What would you do next? Do you have a sort of an idea about this, Tobias? Maybe can I give you the floor? Just unmute.
Yes, hello. No, I'm here today only to have some inspiration for our future projects, because we are interested to improve primary healthcare in Vienna, and we are working together with the insurance, and we have experience with participation in other projects in diabetes for a center for diabetes, and we are interested to make it also for primary healthcare.
But you might have thought about it already, about certain research to be done to see how the quality is now and what it should be in the future. So do you have an impression of what should be done now, or do you want to have more advice on that?
No, I think in Austria we have what's the name? We have a problem in our system because the insurance is paying for the ambulance healthcare, and the city or the state is responsible for the treatment in the clinics. So this is what's the name? Herausforderung in English. This is a big issue in Austria.
Challenge.
And the patients, they are in between, so they don't know where's the best path for them, going to the ambulant provider or to the clinics. And so these are very tough decisions for the patients and also for the system, and we want to improve that.
And you are working now with the health insurance, I understood, Tobias, is that correct?
No, I'm working for the city of Vienna.
No, understood,
and
but
the insurance is our partner.
Yeah, yes, indeed. And so if they are your partner, are they also a little bit of the audience? If you would ultimately have data on the patient perspective, would you then share it with the health insurers?
Yes, of course.
And do you
It's
think
for us, it's for the insurance.
Okay.
And for the patients, of course.
Do you think they need quantitative data or qualitative data? What do you think would work best for this audience?
I think both is important. Maybe quantitative data at first, to look how satisfied our patients are. And then also focus groups and qualitative perspective, of course. I think it's a combination.
It sounds very interesting, and it does make sense, I think, to do a combination. Often stakeholders such as insurance companies or the government, if they make a decision, they really like numbers because it feels like a bigger or better evidence base. I don't think I agree, but anyway, it kind of works well at these tables to have quantitative data. But if they really need to understand, I think also you are talking about these journeys. A patient has an issue and they are in between ambulatory and the clinics, and how do these journeys work, and what are the steps? I think you might need to paint a few of these journeys using qualitative data to really get the discussion on the table. Very interesting.
Lena, you want to intervene in this discussion? Please go ahead.
No, I had a separate question, if that's okay.
Okay,
Sure.
that's also okay. Go ahead.
Hi, I'm Lena. I'm doing research in the Netherlands at the Radboud UMC, with together with Maria van der Muizenberg as well. Hi. And we are choosing PREMs for our research for evaluation of a chronic care program in primary care. And we have the challenge that it's very hard to detect some change on a PREM in Dutch primary care, because we already have a very high level of care, I think. So do you have any advice on how to choose a different PREM maybe to detect change?
Thanks for raising that, Lena. I think detecting change with PREMs can be quite complicated. As you said, care is generally quite well received by patients already. They are often very grateful to their healthcare provider for providing the care they need. So you have generally big scores or high scores. And if you do that scientifically, you need either an excessive amount of data to achieve significance, but then you get the issue: is it relevant? So I think it is a common problem, I think. Did you modify the care pathway, or is it a new care pathway? What happened there, Lena?
So we are trying to give patient-centered and integrated care instead of the disease management programs in the Netherlands. So we want to put everything together and view the patient holistically, and then also get in other chronic conditions. So we modified the pathway, I think. Okay.
And when do you think it is a success? Because it could be a success if people think it is a lot better. But if you know it is a lot better from, I don't know, from a medical point of view, and patients still have the same appreciation of the new pathway, then it could also be a success.
Yeah, no, that's true. So we strive for the quadruple aim. Better patient experience and better population health, and also better carer experience and cost effectiveness. And right now we are looking at a primary outcome of like a combination of the population health and experience. So we either want to make the health better or the experience better, and then we think it's a success.
Yeah, I think, well, you know, it's difficult to just on the spot say something very intelligently, but I'll give it a go. I think also here, do not underestimate the power of qualitative data. And maybe you should think about models for evaluating these things that are more driven by maybe process evaluation or action research, rather than a quantitative pre and post measurement and comparing that. Because I think you have achieved a lot that you will not see in the pre and post measure, as you already explained. And so I really think it requires a different approach.
Yeah. Okay. Thank you for your advice.
Judy Birch said that she has a lot of experience with PROMs within chronic pain management. Judy, could you say a little bit more about this?
Hello, yes, can you hear me?
Yes, go ahead.
Okay. Yeah, so the first time was with the German Research Foundation. They have done a lot of work on developing PROMs for multimodal treatment in chronic pain. And that was an international collaboration. So there were people from OMERACT, and it was a combination of health professionals. So there were physiotherapists, psychologists, clinicians, and patient representatives. And gosh, it started quite a few years ago now. I can't actually remember. And the work is still ongoing, but it's interesting now because they've combined with the National Institute of Health in the US, and there's some joint work going on rather than developing PROMs in several different countries. which doesn't make any sense at all. So it's now, it's called Integrate, I think, and it's just starting. And I'm a patient representative on that, in that work. So there are some American representatives. There aren't that many of us actually, but there's also someone from the Netherlands that I work closely with, who I know very well, as a patient rep. And she hasn't been involved before, mind you, so this is a first for her. And I think she's finding it quite difficult at the moment to grasp what it's all about, basically. And but we'll get there. So yeah, and there's also a lot of work going on with IMI Pain Care, which is an EU public-private partnership. They've also been developing PROMs for a big chronic pain project that's going on, involving 14 countries and 40 partners, of which we're the only actual patient organisation. And yeah, and that again has been several years work. So we're now in, it's a year extension, and that's due to be completed next year. So it's been extended for a year due to COVID. And a lot of papers are now being published coming out from that. So yeah, so I think it's really important that there's coordination with this work, you know, that it's not people doing bits of work here and there, you know, and everyone trying to publish their paper, you know, to get the credibility. So yeah, I'm quite encouraged, you know, that there's a lot more joint work about to start, but it is very time consuming from the patient point of view. I think it's very worthwhile. And the point of these, I think, is to use it clinically and for research. That seems to be, you know, the direction. But yeah, I was interested in what you said about not using disease specific tools in primary care, but the holistic aspect, which of course is also very important. And I don't quite know how you marry the two. So yeah, but thanks for hosting this. It's very interesting.
Thank you, Judy. I had a connection issue, so I popped out and got back in again. But it sounds like you have done a lot of work in this chronic pain management, and confirm that, you know, the complexity of making successful use of PROMs. And I think that's still a journey in many sectors and in many countries on how to do that. And the issue of, you know, do you use very specific measures? Well, that is very good for having very precise and reliable measures, I think. But it's also more difficult to implement, because if you use a specific measure, then you need something specific for each different patient group. And particularly within primary care, I think that's going to be very difficult. I can't really see how you could manage all those different types of PROMs within a practice. So I think you either need something very generic, or maybe something specific for big patient groups. And I think other specific measures, you know, maybe that is something to also do that in collaboration with hospitals where the specialists are there and they could focus on that. Those are some of the reflections I have on this.
Maybe this links to the other question of Dani Mochi about how do you involve patients in the development of PREMs and PROMs. If you have all these different patients with different complaints, wanting to have their treatment on the priority list, how do you include that in PREMs and PROMs if you talk about quality of primary care in general? Are you still there, Dolf?
Yes, I am. Yes. So, yeah. So there's a couple of ways that you could involve patients in the development. I think if you have clear what the population is that you are interested in, it is very good to develop them at the start, and or you develop them to say, you know, if we want to do a survey on PREMs or PROMs, what should be the topics in the questionnaire? And you can identify that with those patients. And if it's a very diverse set of patients and it needs to fit in one survey, then quite likely you will end up with a more generic instrument anyway, because otherwise you can't make it fit. So that would help. The other thing is to seriously also do this usability testing that I talked about. So if you have defined topics with patients to say, okay, these are the topics that should be in the questionnaire, you develop items for that. You can discuss then again with patients, is this complete? Are these the right questions? So that's a step. And then ultimately I would do this usability test or this cognitive interview to check whether all the questions and the answer categories are also interpreted as intended, because if not, then you will get bad data. And if they do understand it the way it is intended, then you will get good. So I think those are a couple of the things that you should do, but I would also like to keep on stressing that at the end, if you have data, then you can also consider involving patients to help you interpret the data. And I think that's a very interesting option. Maybe not appropriate for all types of data, but in generally, I would at least recommend that you consider that as an option. Particularly for PREMS, I think it could be very useful to make more sense of the data to involve patients there as well.
May I ask, we have a guest from Albania, and I've been working in Albania with Doctors Without Borders, so I'm always very interested how things functioning in Albania if it comes to patient experience, and certainly from a nursing perspective. Agron, would you be able to add something to this discussion?
Yes, hello everyone.
Yes, go ahead.
Yes, we have done some researches into the community, but this issue of translating from data to delivery quality, it's a little bit satisfying. Because we have get some numbers, we have get some results, but to get that into the quality of services, to make better experience, to make better services, it's very very problematic.
Have you been able to join certain European projects on this?
Once again, please.
Have you been able to join European projects, so international projects where you can learn from other countries and from other research institutes?
We have found some local projects, not international projects, and we have raised some issues which was in interest of the association and also in about experience patients or citizens with anti-COVID services, and also other minorities population, their experience about anti-COVID experience. And one project was about experience of patients or citizens that was about experience of primary health care. And yes, those was the projects.
Okay, thanks. But I'm very interested in your experiences and how you can join our activities. So we might get in touch with you. Dolf,
yes.
Back to you. You have to wrap up. It's almost 1:30. But you might want to go back to the meter to see what has been covered, or.
No, I think a lot of it has been covered, and I think a minute is not enough to go back to the meter. One thing I would like to share in closing is that, and if we would have had time left, I wanted to also discuss this with you. But through the years, I was trained as a quantitative researcher, and through the years, in terms of PREMS and also PROMS, I came to the conclusion that quantitative methods are often, there are very high expectations of these methods that do not get often fulfilled. While qualitative methods, I think, are a bit undervalued. And well, you may have different opinions about this, but as I'm here as an expert, I thought I share my opinion. I think qualitative methods are a bit undervalued and quantitative methods a bit overvalued in these cases. I see a lot of people nodding, so that is nice to see. Okay.
Well, indeed, many thumbs up. I hope this gave you all some inspiration on further involvement of patients within care delivery, and some techniques, some methods to be used. So, Dolf, thank you very much for this introduction. I all want to invite you for the 4th of May. When Ms. Rojac, a colleague of Sarah Broekman, will talk about a different way of approaching healthcare. So much more looking into the needs of the patients, and to provide, in fact, well, how you call that? Sarah, help me. What was the exact of Daniela?
Social prescribing.
Social prescribing, that was it. So social prescribing, and I think that is really something interesting for all of us. Judy, you want to add one more word?
Yeah, I have to look after my granddaughter on a Wednesday. I think it's on a Wednesday, 2-year-old. So
Congrats.
I don't have any chance to listen. Will it be recorded, and is there a possibility, because it's a very important topic actually for us as well, what we're doing. So
yeah, we will record all the webinars, so you can find them on our website sooner or later. So we will inform you. Yeah. So hope to see you then, and thank you for attending.
Diederik is frozen on my screen, but I think he was just closing off.
On the moment supreme,
Yeah.
like you say. Yes,
Anyway.
but I think then, well, on behalf of the EFPC as a chair, I would like to thank you all for your attendance, and it was very interesting, Dolf. Thank you very much. I've learned a lot, and I hope we'll meet again at the next webinar. So bye-bye, and good luck with everybody.
Thank you.
Bye. Thank you.
Bye-bye.